In practice, with all of these barriers, and they're just human factors barriers, right? What are your strategies to make people adhere better and to help them? Not as an adversarial thing, but what do you do practically to get these things taken right?
So, you know, we actually have a navigator now, and this is going to be hopefully an important change in our practice, because, I mean, I've had patients that I write the prescription. I mean, there's actually a patient just this last week that I wrote a prescription. The patient was in rehab. I came back to see her. She came back to see me 2 weeks later. I wanted to monitor her side effects, and she wasn't on the drug. She never received the drug. And so now we're going to have the navigators sort of make sure that these things work more smoothly. The other thing, and this was actually one of the ASCO plenary sessions, is that they had this web-based program for reporting side effects, not just with oral chemotherapies, with all chemotherapies. And it turned out that, and it was real time, they would send emails to the physician's offices, the nurses would answer those emails, and it turned out that it improved survival, 5 months, which is greater than a lot of our oral drugs do. It also improves quality of life. It decreased hospitalizations and decreased ER visits. And so I think that's probably the direction that we'll be moving. And whether that's an app on a phone or a web-based program, I think that we'll be doing more of that.
So some of the manufacturers, the drug companies, have their own nurse who is assigned to an area, and that nurse will only have maybe half a state or a small geographic area, and they're assigned to follow up with the patient and call the patient. So you can take advantage of the manufacturers. They have a lot of services and nurses that they'll provide to help with this.
At $30,000 a month.
Exactly, they better, right?
Well, and the only problem, I ran into this once where the patient was on one of the oral drugs for renal cell cancer and started having a really bad rash and called up the nurse. And the nurse said, "Oh, just keep taking the drug. Don't worry about it." And so, and not go talk to your doctor.
Wow. Okay.
So
you have to be careful.
They really have to know their limitations and make sure that they're referring the patients back to the doctor.
That's a line from a Clint Eastwood movie. Man's got to know his limitations.
That's right.
But nobody is arguing that bad advice is good. Right. But so we have a nurse, perhaps assigned from the pharmaceutical company. We've got all sorts of electronic devices and follow-ups. Anything else?
Well, we have a team-based approach. So pharmacist, primary nurse model that works with every patient. And we have triggers built into our EHR regimens. So every oral regimen goes into the EHR with multiple oral triggers that nursing and pharmacy act on, from calling the patient, as I mentioned in an earlier interview. For 24 to 48 hours, we get a hold of the patient after the first dispense. They're back into the office at least a week later, just like a patient receiving intravenous therapy. We follow those patients just like they're receiving intravenous therapy, pull them in, make sure they don't have any early toxicities. To Noah's point, especially in multiple myeloma, a lot of these agents have multiple toxicities that you need to stay on top with. The way we do that is through our care teams, and that works fairly well. I think having that close patient contact with your pharmacist and primary nurse is key.